urological problem, they can be corrected and your life can be comfortable. But most of the people at that age group, they are not aware of it. To create awareness among the senior citizen, we are organizing this Zoom session. The set of urological problem in female differs from male. Today, Dr. Ananthakrishnan will give you in brief common urological problem in senior citizens. And Dr. Vaishnavi madam, who is a Urogynaecologist, will explain a particular problem called incontinence of urine occurs in old women due to childbirth, due to inert lack of elasticity. There are various reasons which can be corrected with simple measures. So, hope this talk will help you to identify your problem. You can find out if you have those problems. And any one of you want to come and contact our doctors, please do ring up. At the end of session, we'll give you a number, contact number. And you can fix an appointment to avoid a crowd in the hospital, and comfortably you can consult the consultant to get rid of your problem. Once again, I welcome all of you for this webinar session. Hope it is very useful for you. Thank you very much.
Welcome to CURI Hospitals, where robotics enhances a human touch. Established in 2018, CURI is located on OMR at Thoraipakkam. CURI Hospital's design, built to NABH standards, is inspired not just by the need of its patients, but by the needs of their caregivers too. Which is why, as you walk into CURI, you will find every space ergonomically designed and environmentally inspired. A truly green experience. CURI is a 75-bed facility and one of Tamil Nadu's standalone single specialty hospitals for the treatment of renal diseases. What it means to be a single specialty hospital is that our expertise and focus is never diverted. All our facilities and staff are focused, trained, and dedicated to a single purpose, so that we can deliver the best possible medical care for your needs. Our hospital is designed to cater to all social strata economically, so that no patient will be denied excellent medical care at the time of need. But as the saying goes, a hospital is only as good as its doctor's skills. Which is why we are proud that we have specialists on board, singularly focused on our specialty, urology. To back up and support the skills of our specialists, CURI has the best cutting-edge technology available in all facilities, be it CT scans, ultrasound, urodynamics, dialysis, or just a simple X-ray. And of course, robotics. This ensures that every patient will get the best care with the best technology to back it up. CURI also has a plethora of the best qualified doctors who combine medical expertise with experience. What enhances this expertise is our new robotics technology, which adds a new dimension to assurance and reliability. Robotics in surgery increases better outcome for the patients, taking care and eliminating even small factors like a hand tremor. CURI has invested heavily in this new age technology, and the results have been remarkable. With a commendable success rate, we are already heading towards being a reckoning force in urology in India. Now let's step back a minute and think. Technology and skills apart, a hospital has to be about being humane, which is why our CSR program supports and houses the Indian Prostate Cancer Foundation and the Dementia Daycare Center, with specially designed spaces for both. A multi-cuisine canteen backed by inputs from our dietitians, and kiosks spread across every floor ensure patient comfort with a variety of food and caters to the need of their caregivers. CURI is committed to ensuring total comfort and care for its patients and caregivers. CURI, integrity and commitment towards patient care, backed by medical expertise. CURI, robotics with a human touch.
Yeah, so that was a brief intro about CURI Hospital and its specific super specialty services given to patients. I would like to welcome Mrs. Sita Lakshmi Narayanan, who has a long association with Inner Wheel since 1974. She is a Sanskrit scholar who's associated with so many education institutes. And she's also a very good Carnatic singer. She was the chairman of Inner Wheel District 323. That is the district from 94 to 95. Madam, I am very honored and blessed to have you with us. I would like to have your guidance now and in future to help the senior citizens in coming years. Thank you very much, madam. Now, Dr. Ananthakrishnan Sivaraman, who is a urologist and chairman of CURI Hospital. He will be giving you brief introduction to common problems in urological problems in elderly citizens. Thank you very much.
Dr. Ananthakrishnan Sivaraman is a consultant urologist, laparoscopic and uro-oncologist and robotic surgeon at Chennai Urology and Robotics Institute Hospital, OMR, Chennai. He is also an honorary faculty member at the University of Central Florida. Dr. Ananthakrishnan Sivaraman completed his basic medical schooling at Madras Medical College. His urological training MCH was also at Madras Medical College, where he stood first in the MCH University examinations and was awarded the Professor Rajashekharan Gold Medal in Urology. Further training in uro-oncology and minimally invasive surgery was completed in England at the Whittington and University College Hospital, London, and Eastbourne District General Hospital, Eastbourne. He also completed his fellowship in the Royal College of Surgeons of Edinburgh. He then completed his robotic surgery fellowship training at the Global Robotics Institute, the premier institute for robotic surgery training in Orlando, Florida, from 2010 to 2012. Under the tutelage of Professor Vipul Patel at Florida and as consultant urologist at Apollo Hospitals and director at Chennai Urology and Robotics Institute, he has performed more than 1,000 robotic surgeries. Dr. Ananthakrishnan Sivaraman specializes in minimally invasive robotic surgery and uro-oncology. He is also a national proctor for robotic surgery in India, running a fellowship program for robotics, as well as one of the few robotic surgeons in the world to have performed a robotic renal transplant surgery. He has several publications in peer-reviewed journals and has served as a managing editor for the Journal of Robotic Surgery from 2010 to 2012. He has authored book chapters on robotic surgery and robotic training. He is also faculty in University College London Robotics Centre for the Advanced Urological Robotic course, as well as faculty in Society of Robotic Surgery. Dr. Ananthakrishnan Sivaraman has been conferred a Special Achievement Award in Robotic Surgery by the Bengal Urological Society and the Bengal Urology Society Conference as part of their 50th anniversary celebrations held in Kolkata. Dr. Ananthakrishnan's passion is to help prostate cancer patients lead better lives, and to this effect, he has conducted several national and international camps to raise awareness and educate people about prostate cancer. Dr. Ananthakrishnan is best known for pioneering robotic surgery in South India. Dr. Ananthakrishnan is also the founder director of the Indian Prostate Cancer Foundation, an NGO dedicated to alleviation of suffering from prostate cancer in India.
Hello, am I audible?
Yes.
Yes, sir.
Yes, okay, right. So I must thank the Inner Wheel Club for giving us this opportunity. And, to be honest, I read up about the Inner Wheel Club. It was started by Mrs. Margaret Golding. I think she was a nurse, wasn't she? So there's some attachment there to the hospital. But anyway, I'm a Rotarian myself. I belong to the Rotary Club of Madras East.
Oh.
And, it's a pleasure to address the Inner Wheel Club today. And my talk is going to be very simple. It's going to be about common urological problems affecting women. So I'm happy for you to stop me at any time during this talk. It's going to be a relatively short talk. So ask all your questions, all your doubts, happy to answer. And then you're getting another star speaker after I finish. She's Dr. Vaishnavi, who's a Urogynaecologist as well. So she will clear doubts regarding incontinence. So let me start my talk. And this.
Yes, sir, you can continue.
Yeah, thank you. Right, there you go. Okay, is the screen visible?
Yes, sir. Yes, it's visible, sir.
Okay. So there you go. So this is our hospital. It's in Thoraipakkam, Chennai Urology and Robotics Institute. It's a standalone center for urology, nephrology, uro-oncology, urogynecology. So the scope of the talk today is I'm going to be talking about some urinary tract infections, very, very common for women. One in every 2 patients who walks into the clinic has urinary tract infections. And then we'll talk a little bit about stones, then minimally invasive surgery, which is robotics. And finally, Dr. Vaishnavi will talk about incontinence. So let's start off with urinary tract infections. Why do women get UTIs, urinary tract infection or UTIs so commonly? And when you talk about UTIs in women, there are some anatomical reasons. One is a short urethra. So if you look at this picture, the length of the urethra for women is about 4 centimeters. But the length of the urethra for men is 20 centimeters. So, the distance from the external meatus to the bladder is only 4 centimeters. So easy for bacteria to walk inside. The next is estrogen levels. As the estrogen levels come down, there's potential for more infections. Then holding pattern. That's something that we need to look into. Usually we see a lot of women try and control the number of times they pass urine, and a lot of reasons for that. One is they don't get a proper place to, a lack of good toilet facilities is one of the biggest reasons. And what do I mean by the next one? Adjacent source. If you look at urinary tract infections in women, 99% of them are the sources from the back passage or the rectum, right? So we have this common misconception that whenever women have UTIs, they would say, I went to a different toilet, or I went to a toilet in a hotel or a railway station, and then I got a urinary tract infection. Usually that's not the cause. The cause of the infection is from our own body. That is from the back passage, right? So if you look at, if you culture the urine and look at what sort of infections they have, 99% of those infections arise from our back passage. Then I'll talk a little bit more about that. Then the menopause. Post-menopause, estrogen levels in the body come down, And this in turn makes the urinary passage, the urethra, a bit rigid. So it's easy for the bacteria to get into the bladder. And then menstrual hygiene, diabetes, and constipation. I'll touch about all of these factors a little bit as we go on. So this picture is very, very important for us. So it gives us an idea of how close the urinary passage is to the back passage, right? And for women, this entire perineal area will be colonized by bacteria from the rectum. So for all men and women, it happens. But because for women, the urinary passage is so close to the back passage, the potential for this bacteria to head into the urinary system is very, very high. So that's something we need to bear in mind. Okay. So how do these urinary tract infections present? Right? It's either cloudy or dark urine or blood in the urine, pain in the pelvic area, and then burning sensation as we pass urine, and the urine has a strong odor. And then you have this massive frequency. You want to pass every 5, 10 minutes, 20 minutes, 30 minutes. You have this urge to pass. There's some burning, some dysuria. So it really shows up and tells you that you do have an infection, right? Out of this, the most important thing is blood in the urine, right? If there is blood in the urine, I've seen a lot of our patients just go to the pharmacy and take some antibiotics and then it settles down and stuff like that. Blood in the urine has to be evaluated. We can't just assume it's because of urinary tract infection and not get it evaluated properly, because there could be other reasons for blood in the urine. So if you have blood in the urine, make sure you get yourself checked to see. There are 2 types of blood in the urine. One is called macroscopic hematuria, which is, you can see it with your eyes, it's blood in the urine. Now, the other thing is when you do a urine test and then they look at it under the microscope, they would say that there's some blood cells in the urine, right? Even that is something that needs to be evaluated. Even if you don't see it with your naked eyes, you need to be, you should evaluate blood in the urine, right? So what do we do? How do we take a urine sample, right? So the first thing to do would be to wash the genital area and then to split the 2 labia and then allow a little bit of urine to pass and then collect the sample. So that's important. Let's not just collect the first sample that comes, first bit of urine that comes out. You should take something called the midstream urine. So wash the genital area, split the labia, and then collect the urine sample. So this has to be sent for urine routine and urine culture. And the reason we ask you to collect the midstream urine is because when urine comes out, it passes through, when it passes through the urethra and touches bits of the vagina around, it could give us a false answer saying that you might have some bugs in the urinary area and stuff like that. The best thing to do would be to wash first, split the labia so it doesn't touch the outer skin. And then as you're passing, leave a little bit first and then collect the urine sample. That's important for us to do. The next is mandatory for us to check blood glucose levels, right? So it's very simple. Think of it like this. When people have high diabetes and more sugar passes in the urine, and now there are certain medications that the diabetologists give that push sugar in the urine. So because sugar comes in the urine, and as bacteria need sugar for survival, so they kind of stick around that area and cause an urinary tract infection. So blood glucose levels need to be monitored very carefully. And in patients who have recurrent urinary tract infections, we should look at what sort of diabetic medications they're taking. They shouldn't probably have medicines that push more glucose in the urine. Okay, that's important for us to understand. Now, gynecological evaluation, I think Dr. Vaishnavi will talk a little bit more about this. But from my standpoint, with regards to urinary tract infection, you see the amount of estrogen comes up to a peak when women are in the 35s and 40s of their age, and then slowly starts to decrease as they become less and less younger. So what happens? Because the amount of estrogen level comes down, estrogen is very important to keep the urethra, that is the tube that leads from the bladder to the outside. that tube to be pliable, estrogen is very important. And if that isn't pliable because of estrogen deficiency, that tube becomes rigid, then the proximation, that is the tube's ability to prevent bacteria to walk into the bladder is a bit compromised. So as the estrogen level comes down, the tube's pliability comes down, the urethra's pliability. And as a result, the amount of urinary tract infections can become higher. So that needs to be looked into. So how do we check that? We would ask you to do a urine flowmetry, which is how well you're passing urine. Usually women have exceptionally good flows. They sit down, gravity helps them, and then the very short urethra, and the sphincter is a bit weak there. So they would just pass urine very comfortably. But as, because the estrogen level comes down and the tube becomes rigid and a bit tight, and they may have something called the distal urethral stenosis, which is a blockage of the tube, and then the urine flow is not good. So if you look at it, this red line is the normal flow, perfect, right? And then this, as it comes lower and lower, and gives us an idea that the tube is a bit compromised. And for that, we can treat you. So next we would want to do an ultrasound. Ultrasound would tell us how thick the bladder wall is, how much urine you're retaining. So normally there should not be any urinary retention, right? So women should be able to, discharge all of their urine. But if some urine remains behind in the bladder, then that can be a source of further infections again and again. So the post-void residue is very, very important for us to understand, right? Next, over and above that, sometimes we may need to put in a camera through your urinary passage and look at your bladder to see if there's anything else going on, if there's infection alone or something going on in the bladder in terms of a bladder mass, or the bladder capacity is small and that's why you're passing so frequently. So all these things are evaluation tools that we as urologists use to find out what is the cause of the trouble that you have. So how do we treat these UTIs? So the usual stuff is common. So I'll tell you, best thing is not to hold your urine at all. If possible, number one, try and drink a lot of urine, pass a lot of urine. You should go ahead and not hold urine. That's important. Right? Number two is, after intercourse, the genitals need to be cleaned very well. So that's important because I'm going to go back to this previous slide. So in this slide, you see, so vagina, rectum, bladder, they're all very close to each other. So any activity here in the vagina has a potential to propel bacteria into the bladder. So very, very important that we clean our genitals before and after sexual intercourse. And more important is to pass urine after sexual intercourse. And the reason is, during sexual intercourse, bacteria gets into the bladder, and we see a lot of newly married women have something called honeymoon cystitis. What happens is, after intercourse, they would go sleep, and then the bacteria has enough time to stay in the bladder and cause a urinary tract infection. So the best thing to do is pass urine before going to bed. After intercourse, pass urine, and after that only sleep. Don't allow the urine to stay inside the bladder and trouble you, right? And constipation also has the potential to trouble us. Why? Because I told you most of the infections are from the back passage. When somebody has constipation, the amount of bacterial load in the back passage is very, very high. So that further has a potential to cause a urinary tract infection. And when we wipe ourselves, post-urination or post-defecation, always the plan should be going from the clean area to the dirty area. So front to back. Okay. So what else can we do that's generally useful to prevent urinary tract infections is, nylon undergarments are not good. Best is to have cotton undergarments. Always have cotton undergarments, not nylon undergarments. Okay. So, right. I can see Mr. Ranganathan there from part of our Rotary Club. Hello, sir.
He's changing.
Okay, let's go on to the next one. All right. So the next is, so we touched a bit about the urinary tract infections. And the next step is usually you'd go to a doctor, they would do a urine routine and culture, and then we'll treat you with the antibiotics. And these antibiotics are based on the culture report that we see. Okay. So if the culture shows an infection, then we would treat it with the appropriate antibiotics. And the next step would be, it's usually for courses about 3 days. It can be for 7 days, depending on the severity of the infection. And sometimes we would give a long-term, low-dose antibiotic for at least 3 months period. So this in general is treatment regarding urinary tract infections. Next, let's go on to urinary tract stones. Right? Stones are one of the common reasons that women come to us as well. Right? We tend to get a lot of stones, especially in the summer season. And usually they form in the kidneys and then travel down through the tubes. So they can get stuck anywhere in the tube. If they're in the kidney, the stones won't trouble us too much. But if they do get down in the tube, then the potential for them to cause pain is extreme, right? But, you know, a lot of patients, especially men, come to us and say that this pain is unbearable, right? But women are a bit better in that. We don't get men that say that's extraordinarily high pain because they've already gone through more pain when they had childbirth. So when you look at this pain score, the highest pain is in childbirth, and only then comes the urethral stones. So most women already have had a little bit of that pain, that severity of pain, and so they can take it. But men, they kind of cry like babies, actually. So that's I always tell them, see, your mother would have had more pain or your wife would have had more pain. So don't fuss too much or something like that. So the next is, it's more common in men. Men have it 3 times more common than women. And the types of stones are usually calcium oxalate, oxalate stones, struvite stones. I won't go into the details, but one of the most important reasons for formation of kidney stones is dehydration, right? Especially in a country like ours, where if we go out in the sun a lot, then this potential for urinary concentration is very high. And as a result, small crystals form in the urine, in the kidney, and then they slowly become like slightly bigger crystals and slightly become bigger and bigger and become like sand grains, and then finally become like small pebbles. So when they become the size of pebbles, then they would cause trouble. Right? So that's important for us to understand. The most commonest cause for urinary stones in a country like ours is dehydration. So a lot of people ask me how much water is good for us. It depends on the work that you do. If you're sitting in an AC room, morning to evening, then the amount of fluid that you need is going to be lower. If you're a person that goes out in the sun a lot, then the amount of fluid that you need is going to be much higher. So how do we assess how much? So when you pass water, when you pass urine, the color of the urine should be colorless. That's probably the best way to assess how much water you need to drink. So make sure the color of the urine that you pass is relatively colorless so that you're well hydrated. It means you're well hydrated. Okay. What are the causes? The symptoms. The most important symptom, the most commonest symptom is pain. People will have severe pain, severe pain, right? And then they can present with some nausea, vomiting, again, blood in the urine, and frequent painful urination. And sometimes they have a potential, they can have fever as well. So when they have fever, it kind of becomes an emergency. So in the face of an obstruction, which is the passage from the kidney that's blocked, then you would, if they have fever, then it becomes a medical emergency. We need to see them immediately. Right? So there's a small video showing, I told you, it becomes tiny stones will usually fall out by themselves, right? As the stones become bigger, then the ability to come down gets compromised. This tube is only 4 to 5 millimeters thick, and as it comes, this is your kidney, as it comes down from the kidney, there are several areas that are a bit narrow, and it won't allow the stone to pass through. And the important thing to understand is it doesn't come out very easily. It'll scratch the sides, cause bleeding, cause pain, and so on. The important thing is to understand is this tube doesn't have pain sensation. So if you cut the tube, you may not have pain. But if you allow it to distend, then it'll have severe pain. Okay? So urine doesn't travel by gravity from the kidney to the bladder. It travels by a method called peristalsis, which is the tube sequentially compressing and relaxing so that it pushes the urine down towards the bladder. So when the tube is peristalsing, if there's an obstruction, that is the cause of the pain. So the peristalsis cannot push the water down and it distends the ureteric tube, and you have a lot of pain because of that. So what are the controllable risk factors? Fluid intake, very simple. Prevent dehydration, and dietary factors. There are n number of stuff that is available on the net that tells you that you can do to prevent urinary stone formation. But the most commonest thing is drink more water. Simple, right? You don't have to do massive changes in your diet, right? If you're a regular stone former, then we need to follow a specific dietary advice. We will do something called a metabolic workup to find out how much salts you're producing in the urine, so that we can titrate the amount of stuff that you take. But if you're a normal person, South Indian diet, the best thing to do would be to take a lot of water to prevent urinary stone formation. Okay? Right? So how do we break the stones? There's one method called shockwave lithotripsy that we can try and potentially break the stones without touching the patient, sending shockwave through the body. But that's not, we can't guarantee that the stone would be broken by that method. Some stones might be like bricks. You touch them, they'll break. Some might be like granite. You hit them, and they may not break. So shockwave lithotripsy is you can never be too sure that it will break the stone. The commonest way of breaking stones now is putting a camera through your urinary passage and going up to where the stone is and lasering the stone. So if you look at this video, we just go through the tube. It's a very, very tiny tube. It's as small as the refill of the pen. So as it goes up to the stone, we'll kind of pulverize the stone with the laser and then collect it in baskets and then bring it out through your urinary passage. So there's no cutting or stitching for stones nowadays. It's only through your passage, and then we leave a stent behind and come out. And then there's another way when we're tackling very big stones, and then we can go through the back and then make a slightly bigger opening, again break the stones, pulverize them, and then pull them out through the camera itself. So there's no open surgery for stones anymore. That was done 20 years ago. Now it's pure and simple endoscopic surgery for all stones, right? So again, we've talked about urinary tract infections. We've talked a little bit about stones. Let me give you a quick idea of what robotic surgery is. So all of you have heard of this gentleman, is Shushruta. Ancient times, he's considered the father of surgery. More than 1,500 years ago, he was 1,500 BC. He was teaching people surgery here, when the Western world was still running about without any form of civilization. So that's how ancient our culture is. And but this is, let me give you an example of how things have evolved. So this is 1600s in France, okay? And you see one gentleman doing the surgery, one gentleman's the patient, and you have 3 other people holding the patient, because we didn't have anesthesia those days, right? So the patient would run away because the pain was a bit too much. And this was 1800s, Mayo Clinic, Massachusetts, in Massachusetts, not the Mayo Clinic. So this was introduction of ether anesthesia, so we could operate on patients without them running away. And then here was Joseph Lister, the gentleman who introduced aseptic technique, so we could operate on patients with anesthesia and without infections. And then we started the era of big surgeries where we could take out anything and put back anything. I'm not going to show that picture for a long time. So that was actually a kidney transplant being done. But we were putting massively big incisions. So already the patients who come to us are not the healthiest of people. And if we put a big cut on them, then the healing power is also compromised. So we needed a minimally invasive way of doing surgery. And that's where laparoscopy came in. But laparoscopy had a lot of negative points in terms of loss of depth perception, hand tremors, range of motion is decreased. And that's why we got robotic surgery. So we wanted to maintain the minimally invasive approach without losing the advantages of open surgery. And that's where robotic surgery came into the picture. So what are the advantages? So there's improved visualization. We have 10 times the magnification that we have with laparoscopy in robotics. And then instrument control, and dexterity, and superior ergonomics. The surgeon is sitting and operating 10 feet away. So this is where we sit and operate. This is the robot that goes into the patient, and there's a vision cart as well. So this is the camera. It's a binocular vision camera, and that's why we have 3-dimensional images, right? Tiny instruments, so that the openings are less than a centimeter, millimeters. Okay, and there's wristed instrumentation, which is not available in laparoscopes. So I have this ability of using my wrist when I'm operating. And a lot of patients ask me this question, sir, when you say it's robotic surgery, is the robot operating or is the doctor operating, right? So the answer to that question is, it's a master-slave mechanism, which means that it will not move a millimeter without the surgeon using the control. So in the next video, you'll see that what I do outside happens exactly inside. Only thing is through tiny incisions that go inside, right? The instruments go inside, and this is how we sit and operate. So what I do outside by moving these external controls, if I need to cut, so these are instruments that have been placed inside the tummy already. So this is what happens inside. So the advantage is exactly similar to open surgery, but we're using the minimally invasive approach as well. So that's the key here. So all surgeries, what surgeries can we do with the robotics? It started out with urology. So any kidney surgery, prostate surgery, bladder surgery, we do with robotics now. And a lot of gynecological surgery has also come into the picture. Hysterectomy, fibroid removal, all of that can be done very, very well with robotics. So I'm going to show you another quick, so this is how it looks like. So this is where we sit and operate. This is what goes into the tummy of the patient, or these are the arms that, and this is the vision card. So here's another quick video. This is the hospital that I trained in the US. So you see the tummy, the patient's head is towards us, the legs are away from us, and this is how the robot comes in. So we've already put tiny instruments here in this tummy of this patient. And here you see this instrument, the robotic arms being attached. And once we attach the arms and put the instruments inside, I would go sit on a console that's about 10 feet away from the patient. And what we do on the console happens inside. It's exceptionally good, technique for cancer surgery, especially for prostate cancer, bladder cancer, kidney cancer. So very good. So I'm going to ask you a quick question. Are you okay to see a small video where you see a little bit of blood? Or if I'm going to ask Mrs. Lakshmi Narayan, if you're okay, I'll show you that video. Otherwise, we'll skip that video.
Go ahead, please. Let us see what it is.
All right. Okay. All right. So it's not anything major. I'm going to show you a simple example how robotics can help peculiar problems. So there you go. So in renal surgery, so this is the kind of surgery that we can do. We can remove the kidneys, remove only a little bit of tumor from the kidney, then remove obstructions from the passage and so on, right? So this is the kidney here. This is an X-ray image of the kidney. and there's an obstruction at this level for this particular patient. Okay, so what we need to do is cut this area and then stitch it back together. So usually if I have to do that, I have to put 2 of my hands into the tummy. So if 2 of my hands have to go inside, imagine the size of the incision that the patient will have, right? So this we can do very, very well with robotic surgery. So this is how it looks like. So that's the video. So this is the tube that I was talking about. Can you see this? This is the tube that has got an obstruction, and this the size of the instrument is just millimeters. So this is the main blood vessel that goes to the kidney, and this main blood vessel is causing this obstruction. So you have this big balloon kind of entity here. That's the pelvis, and this is the obstructed area. So we're cutting the obstructed area and cutting the area that's obstructed and stitching it back to the kidney. So again, 2 instruments, the size of each instrument is, the thickness of each instrument is 8 millimeters. And after the end of the surgery, patient stays in hospital only for 24, maximum 36 hours. They're walking in 4 hours time, they're drinking in 4 hours time, and they leave the hospital within 36 hours. So that's one of the key advantages of robotic surgery. And look at how we're able to suture, the angles that we're able to achieve. Exactly similar or even better compared to open surgery. So the access is minimized, but our ergonomics and our ability to move in different angles is not compromised. So that's how we stitch these 2 together. So you see the size of this is somewhat similar to the thickness of our hair. So that's how thin this 5-0 suture, very, very, very thin suture that we're using. And the key advantage is it doesn't cause damage to the area that it stitches. So again, there's a stent that's placed inside. All of you have heard of stents that they put in the hearts. Now this is a stent that we put inside the tube that allows the tube to heal. And that stent can come out in about 6 weeks' time. So I won't trouble you too much with this video. You've already seen a lot of blood. I'm going to stop this video and then we'll go on to the next slide. So this is again one of important things. So 10, 20 years ago, if somebody had a kidney cancer, they would remove the entire kidney. But now that's no longer acceptable. With robotics, we have the ability to remove only the tumor and save the rest of the kidney. So that's something that's important to understand. So we've touched upon urinary tract infections, we've touched upon renal stones, and then we've touched upon minimally invasive surgery. And then next you have the star speaker, Dr. Vaishnavi, who's going to talk to you a little bit about incontinence. I hope this was useful, and I'm more than happy to answer any questions that you might have.
Thank you, doctor. Thank you so much for the wonderful and for useful information. And people are really happy. They have given the feedback that very happy to know about the robotic surgery, how it happens, and how doctor does the surgery. And delegates, do you have any questions to ask to Dr. Ananth?
Happy to answer.
Let's put it in the chat. You can answer later if you have time.
Okay, that's good.
All right.
Okay, we will move on. Before moving on to the next speaker, I would just request Mrs. Sita Lakshmi Narayana to talk about the Inner Wheel Club for a few minutes now.
Yes. Thank
Over
you.
to you. Yeah.
Namaste to all. This is a small introduction to the CURI team. Inner Wheel is a worldwide organization. We are in 104 countries, over 1 lakh members. In India, we have more than 45,000 members. We will be celebrating our Inner Wheel centenary in 2024. Our motto of Inner Wheel is friendship and service. This is about the Inner Wheel movement in general. South Club, that is Inner Wheel Club of Madras South, we serve in the areas of healthcare, education, rainwater harvesting, lake restoration, and geriatric care, and so on. There is no area of service that we have not touched upon, both in cash and kind. We believe in personal service and not in checkbook service. During this COVID crisis, We have donated food and groceries to migrant laborers and also kits to the healthcare workers. Doctor, your speech was so clear and in very simple language. In Sanskrit, there is a saying that says, Vaidyo Narayano Harihi. So, Doctor Sir, Sriman Narayana himself. Namaste. Thank you so much.
Thank you, ma'am. Now, just a small introduction about the next speaker for the day, Dr. Vaishnavi.
Dr. Vaishnavi is a consultant gynecologist and obstetrician and urogynecologist consulting at CURI Hospital. She has specialized in obstetrics and gynecology in India and abroad. Dr. Vaishnavi is an alumni of the illustrious Madras Medical College. After completion of her MBBS, Dr. Vaishnavi was selected to an MD program in obstetrics and gynecology in the same premier institute. Following completion of her MD, she obtained the much coveted British Council sponsorship in view of her academic achievements to train in the United Kingdom. Dr. Vaishnavi went on to work in multiple centers in the United Kingdom and gathered experience and expertise in various specialities that were not available in India for a period of more than 10 years. During this period, she was awarded membership of the prestigious Royal College of Obstetrics and Gynecology, MRCOG, London, and Diplomate of the Faculty of Sexual and Reproductive Health. Dr. Vaishnavi was also selected to a substantive consultant post in Dundee through competitive interviews in 2012, immediately following her CCT UK training. However, she returned to India in 2016, having given up her consultant post in a large university teaching hospital in the UK with the sole aim of making a difference to the care of women in India. Dr. Vaishnavi is a vehement protagonist for the voice of women, especially the less privileged and vulnerable. Dr. Vaishnavi has a keen interest in community gynecology and preventive health. Presenting you, Dr. Vaishnavi Lakshman.
You are not audible.
Ma'am, your voice is not audible. No, ma'am.
Not at all.
Call over internet.
Ma'am, you connect with call over internet. Yes, ma'am, you got connected.
Yeah,
And you can start your video also, ma'am. Fine,
can you
perfect.
Can you see the video? Yeah, can you
Yes,
see
ma'am,
me now?
perfect.
Right. Good evening, everybody, and it's I suppose you can, as long as there's no problems, and if you can see me and hear me, I'm just going to carry on. The Zoom experience is new to us all, and not seeing an audience is always a drawback. But it's just lovely to be here today. And it's always very enriching to speak to a group of women, because it's not just one person you're speaking to. They always quite immediately pick up all the information, only if it's sensible, implement it, of course, if it's reasonable, and then almost always, like I say, widely share it with family and friends. So, like I say, imparting information to women is extremely enriching. So with that background, let's move on to this small talk that I've put together for everybody. Now, if you don't mind, what I have done is I have put together a series of slides based on some questions that I've had at a recent panel meeting about urinary incontinence and incontinence in women. So it'll just play out as answering various questions, and I'm hoping you'll have more questions. So it's a simple 10-minute presentation, and I'm hoping we'll have time for plenty questions and answers. Yeah, can I have the next slide, please? So incontinence in women can be urinary incontinence, can be fecal incontinence, can be vaginal incontinence. We're going to speak about primarily urinary incontinence and fecal incontinence. So when we speak about urinary incontinence, extremely common problem. Say if we were to do a short questionnaire on all people in a room, about 50%, so half the people in a room would have had an episode of incontinence or struggle with incontinence. So it is just very common. So there are two types of urinary incontinence. One's urgency or urge incontinence, which is leakage when we have to rush to the toilet. And the other kind is stress urinary incontinence, when there is leakage, when the patient laughs or sneezes, there's involuntary leakage of urine. Next slide, please. Another type of incontinence is fecal incontinence. We have an international body for urogynae problems, and they say if a woman experiences incontinence of feces, either liquid or solid, at least once a month, then they're classed as having fecal incontinence. It is extremely distressing, as one can imagine, and it is pointed to a lot of systemic problems too. Next slide, please. So if you can imagine, that's a picture of the rectum and the anus, and then the anal opening through which the feces is expelled. And what's marked as external and internal are just a bulk of muscle, which is meant to help women keep the continence, meaning keep control. So when this doesn't work, fecal incontinence, flatus incontinence happens. Next slide, please. So why does it happen? Dr. Anand quite beautifully detailed about menopause and lack of estrogen and various reasons why UTIs happen. So similar reasons actually, but commonest cause of incontinence is childbirth. And a lot of patients quite rightly ask, childbirth happened 20 years ago and I didn't have a problem then, doctor, so what now? I'm in my 40s and why do I have all the incontinence now? And it's because of a combination of factors. When you're young, the various other muscles and nerves make up for the loss of muscle tone in the pelvic floor. And so you're able to keep continent. Whereas with time, and when these muscles lose their actual strength, the incontinence happens. Next slide, please. So age is a huge factor. So when I said the incidence of urinary incontinence is about 40 to 50%, it's mostly in women over the age of 40. In women who are younger than 40, the chances of somebody having urinary incontinence is much lower, almost half that. Next slide, please. Again, menopause, very, very, very common problem. And it's not perceived as a problem. I have patients in clinic who ask me, but doctor, what is menopause? So what if my period stop? I'm quite happy. But menopause has, has a way of slowly growing into you. It's not a disease. It is not cancer, but it can cause quite a lot of symptoms. And one of the earliest symptoms is urogenital aging, meaning a loss of ability to control the bladder, the bowel, and a bit of redness, a bit of burning. So quite a lot of urogenital symptoms, quite a lot of bladder genital symptoms really, along with a little bit of flushing, some mood changes, loss of memory, irritability. It causes quite a lot of problems, and if attended to, can be taken care of quite easily. Next slide, please. So quality of life. The reason I put this slide here is, like I said, urinary incontinence, fecal incontinence is not cancer, but it affects quality of life significantly. And a lot of people ask me, a lot of friends, family ask me, yes, I've had a little bit of incontinence, but when should I seek treatment? When should I go to a doctor? If it affects your quality of life. Yeah, as women, we're all very tolerant. We change things around a lot for other people, but these changes should not affect your quality of life, meaning, just to concentrate on the last 2 points here, mobility. I've had a patient who lost a job as a secretary in an office because of urinary incontinence. She could not get from home to the office, which was a 20-minute walk, because she had urgency. She had to pass urine all the time. And in her office, she kept going to the toilet, and a boss just thought she was, finding ways to avoid work. Now, culture and leisure, again, I have lots of patients who are, can we go back to, can we stay on the slide for a minute, please? Yeah, I have lots of patients who love to do the music in their sabas in the winter and the rest of it. And they have a real problem because, one, like Dr. Anantha mentioned, not many facilities have a good toilet. And if you have a real problem holding your bladder and you have to be in and out of an auditorium, you can imagine what it can do to your entire evening. Now, these problems should never stop you from enjoying life, over and above what you have to do on a daily basis. Next slide, please. So what is the real cause for urinary incontinence? The main cause is urogenital aging, meaning weakness of the pelvic floor muscles and ligaments, and not holding the bladder and vagina and bowel like it should. But what are the other causes? I don't think we need to go through this in too much detail because it's been beautifully covered already. Early infection. Commonest cause of urinary incontinence is an infection. So when my patients come to clinic, I always check them for an infection. Systemic illnesses, a very first sign of diabetes, sometimes first sign of a mild renal problem, which can sometimes be completely asymptomatic. Worsening neuropathy. I'm sure you've seen the, low backache, joint pains are very common in our country. And I'm sure you've seen a friend, a family member who has a little bit of pain in the back, and then it slowly starts getting worse. They're still limping around. They're just limiting their mobility, not getting help. And it can sometimes compress the nerve and cause problems with the bladder. Yeah. Now, the other very common thing that we see in clinic is when women come to clinic, they have a real bad problem with their bladder. They're either not able to pass urine, they just lose control of their bladder completely, or they have an urgency and have to go every 5-10 minutes. And this has all just happened 6 months ago. And quite often we find that there's maybe a mass, an ovarian cyst, which they've been completely symptom-free from, or a large fibroid that has not caused any problems so far, that is suddenly increased in size, that needs attended to. There are some people that have other pelvic masses, such as like an inflammatory bowel disease, an inflammatory mass, things like that. So urinary incontinence actually opens up an opportunity to investigate for various other things and make sure there's nothing else wrong going on with you and with your body. And of course, the biggest thing we are all worried about is cancer. So if you've had that little bit blood in your urine, a little bit bleeding per vaginum, it's always important that you're investigated. Next slide, please. So where CURI is just perfect to have your urinary. I'm not just saying that because I work there, but they have all the facilities, and a lot of the corporates do not have all the facilities to investigate urinary problems completely. We have a good urodynamic setup, good facilities to have cystoscopy, good availability of pelvic floor physiotherapists, everything we need to treat urinary incontinence. Next slide, please. So why not? So when I was at this panel discussion, one patient quite interestingly asked me, yes, I have a little bit of urinary incontinence, but I don't want to go to the doctor because, one, I don't want to, be shoved into a room and be told I need surgery. And the next thing I know, my entire family is descending upon me and they're all worried about me. And I just don't want to go through that. So what if I have a little bit of urinary incontinence and I'll just wait and see if I can manage it the way I'm managing it now, the way, like some people don't drink enough water, then end up with other problems. Some people stop going out, stop doing things they love, and then they end up with problems with mobility. Some people stop doing their jogs and their walks and their swimming, and because of urinary incontinence, and that gives rise to other problems such as high cholesterol and hypertension. So an early opportunity is lost. And the other thing about coming in and having this set of assessment and investigation at an early stage is minimally invasive and very minimal intervention. For instance, small operations, pelvic floor physiotherapy, mild medication, good physiotherapy will all make you feel better. And you can carry on with, as normal as possible for the rest of your life. So that is the advantage of early intervention. Whereas when a patient comes with quite severe incontinence, it is invariably surgery. And surgery needs to be quite advanced and quite thorough. It is, again, like Dr. Ananthakrishnan quite clearly and beautifully demonstrated, it is now a lot more easier, done with a lot more precision. So therefore it is less painful, less hospital stay, and it's not such a big deal. But if you can avoid it, that I'm sure we all agree is the best way forward. Next slide, please. Right. So what for? Why? Again, this was one of the other questions. So what happens when I come to the clinic if you're saying, okay, we're not going to shove surgery down your throat. It's not what we're going to advise everybody. What else? Lifestyle modification. Now, the commonest lifestyle modification that I talk about, that I almost bully everybody into adopting, is reducing the number of teas and coffees that we drink. I'm a culprit myself, so I cannot do without my teas and coffees myself. So, but a lot of people who drink a lot of teas and coffees have significant urgency of the bladder. Now, this kind of, the incidence of this increases with age. Again, it's compounding factors, but you'll find that if you reduce the amount of teas and coffees that one drinks, the urgent incontinence definitely reduces. Of course, the other culprits are citrusy drinks and colas that a lot of people don't tend to do, and most people that I see are reasonably healthy with regarding to carbonated drinks and the rest of it. Just an interesting story, and I always quote the story when I talk about lifestyle modification. I had a patient who was actually very healthy, took care of her diet so well, went on a regular walks. She took care of herself and her husband really well. Now, she had started drinking green tea as a health drive to lose weight and to keep active. And she hadn't put the two together. And this had happened a few days, or maybe a few weeks after she'd started a green tea. And then she started having quite bad incontinence. So, tea, even if it's green tea, can cause bladder irritation. So the herbal teas are quite good. Milk is quite good. Any kind of other fruit juices other than the citrus juices are quite good. All our soups are really good, but we have to avoid what we call the bladder irritants. Again, weight loss. Very, very commonly observed in the over 40s and 50s, when women just slowly start to put on a lot of weight, and because of the pressure on the pelvic floor. If you look at the picture accompanying this slide, there's a little red diaphragm just below the bladder, uterus, vagina, and the bowel, and that is what we call the pelvic floor. So the more weight one puts on, the more pressure on the pelvic floor, and the less it's able to hold everything up. Estrogen supplementation, again, there's estrogen receptors along the bladder wall, along the vagina, and sometimes giving patients a little bit of estrogen, just cures the patient of bladder problems. And physiotherapy is very, very important. So this pelvic floor, or this hammock that you see, has lost all tone. Just like say your biceps or triceps is lost also because it's not been used for a long period of time, and it has been damaged during childbirth, and maybe along the way with increase in weight, it has suffered a lot of trauma. So physiotherapy helps one to identify these muscles and to tone them. The more you tone them, the better the chance of women keeping their continence. Yeah, so it is a very, very useful intervention if done diligently. Next slide, please. What else? There's medication for kind of urgency, or what we call overactive bladder, which is incontinence with a sense of urgency. There's medication that you can have, very effective, and it's effective in about 70 to 80% of the women. Surgery for stress incontinence or leakage of urine with laughing and coughing is again very, very effective. Minimally invasive surgery, day case, tiny tape inserted in your vagina, again, extremely effective, up to about 95% effective. There are other modalities such as Botox, sphincter injections, which are again smaller operations, so can be offered in women who cannot take a general anesthesia, etc. But now the advent of laparoscopic surgery and robotic surgery, and this has been available and easily available to this part of Chennai, with CURI being in the foray, has changed a lot in the in the management scenario, and is really, really very helpful for patients. Next slide, please. So a lack of pelvic floor tone causes prolapse as well. So what you see on the left side is pessaries. So when you ask me what else, if not surgery, because everybody's worried about surgery, and I don't know why. Like I say again, surgery is extremely safe now. So you do not need to be worrying about surgery, is my usual statement. But if you do want to try without surgery, then if a patient has prolapse, for instance, we try these pessaries. If the patient has stress incontinence, like we just discussed, we put in this tape, and they're very effective. What you see on the right is the tension-free vaginal tape for stress urinary incontinence. Next slide, please. So again, these are surgeries that can be done robotically with super precision, very little pain, short post-operative stay, and home in about 2 days' time. So the picture you see on your left is a sacrocolpopexy, again for a combination of incontinence and prolapse, a mesh beautifully stringed inside the tummy. So what you see at the bottom end of the gray structure is a vagina, and it's just pulled right up to a bony prominence in the pelvis. Yeah, the picture on your right shows another minimally invasive surgery for prolapse. Next slide, please. It is true, life begins at 50, and if you want to be anti-acid and say it's burnt out and spread out and falls out, we could be, but I think the best way forward is to get an assessment, get the treatment, and let's move on with our lives. Next slide, please. And I'm happy to take any questions now. Thank you.
Thank you so much, doctor. That was a clear, very crisp and clear explanation, and people really enjoyed. Delegates, you have any questions to ask doctor? Both the doctors are there. I think there is a question for Dr. Ananthakrishnan Sivaraman. Sir, the question is, how is the post-surgery? Is it painful?
Okay, so any surgery is painful, but with minimally invasive work, the pain is a bit lesser than usual. So I don't think there's something called painless surgery. We are obviously doing some invasive work, but as long as we minimize the incisions, I think the pain is definitely more bearable when you compare it to conventional surgery. I think that's how we need to look at it. I hope that answers the question.
Yes, sir. Yes, sir. Any questions?
Neela wanted to say something.
Okay. So, ma'am, you're typing or you want to unmute yourself? Neela.
Neela, ask Neela.
Okay, we are running 1 minute. Neela. Unmute Neela. Yes, now
Yeah,
we
so
are
the
audible.
question is, the question is that you had given us some, risk factors. Are there any sort of preventive lifestyle changes that we can effect earlier in life, for example, when we are 40, so that something like yoga or any other lifestyle changes? Because you had mentioned Shushruta and Ayurveda might be having some sort of lifestyle change that we can apply.
Is that question addressed to me or to
To anybody, maybe to you, because you had brought up Shushruta. Yeah.
So I don't think yoga can ever be bad. So if you're practicing yoga, I think that's an exceptionally good way of keeping yourself fit and your body healthy. And not only body, the mind also, yoga makes, with meditation, and I think the mind also has an important part to play in this. So if you're asking me if yoga...
And no, not specifically about yoga, but any other lifestyle changes which can help postpone or for incontinence.
So
can I
yoga
add?
Yeah,
can
but
I add?
go ahead.
Yeah. Sorry, did I interrupt you, Dr. Ananth?
No, not at all. Please.
Yeah.
It's your forte anyway. So
yeah. So incontinence, if you're looking at prevention, so there are a couple of things. First, childbirth, and it needs to start, the prevention or work towards prevention needs to start at childbirth. So we need to look at how we conduct our deliveries and the forceps use and cesarean sections. Not that we are recommending cesarean sections routinely, but the pelvic floor needs to be well taken care of at the time of childbirth. The other thing that is really very useful is pelvic floor exercises. In fact, apparently in Japan, all the school children, all the young girls in school are taught how to do their pelvic floor exercises. So, that can really help if one does their pelvic floor exercises regularly. It can keep incontinence at bay for as long as possible. I think that's one thing that you can really do and is really helpful. Does that answer your question? Yeah, you're most welcome. Thanks for asking.
The yoga pelvic floor exercises vandirudhu.
That's true. Yeah, that's true. I mean, it's not like as if that it's something different to our country at all. I mean, it's it's engaging the core, and I'm sure it's just doing it universally.
Neela is another Sanskrit scholar.
Shall I ask my question?
Yes, ma'am.
Can I ask
Yes,
the question?
Jyoti.
Yes, please.
There is some contradiction about taking calcium tablets. Doctor, after our menopause, doctors asked us to take calcium. Then after some time, myself also got that kidney stone and came out from that. But after that, I'm not ready to take calcium, all because of the pain and everything. Then the diet, the tender coconut, somebody is telling that take tender coconut for a stone problem, but somebody is telling it is not good for, it depends on the stone, nature of the stone. No, doctor?
Come on. So it's a very good point you raised. So it's not, you can't pigeonhole everybody into the same set of guidelines and say this is good for you, this is not better. So in terms of water intake, 2 to 3 liters of water per day is exceptionally good. But depending upon the type of stone that you have, then calcium intake or tender coconut, all this needs to be taken in moderation. So anything in moderation is acceptable. So
do you come here?
If you've been given the calcium because of the bone weakness and stuff like that, then I think you should take the calcium, right? Along with that, continue the amount of water that you've been advised, at least 2 to 3 liters, so that the urine color is colorless. That being the case, I don't think you'll have a lot of trouble. But you have a propensity to form stones again and again. In that case, there are other options to get your bones to where it needs to, other than just calcium supplementation. So anything in moderation is acceptable. So, நம்ம தமிழ்ல வந்து இந்த தக்காளியோட சீட்ஸ் பிளஸ் நிறைய தக்காளி சாப்பிட்டா அந்த மாதிரி பிரச்சனை வரும், நிறைய கீரை சாப்பிட்டா பிரச்சனை வரும்னு சொல்லிடுறாங்க. அது வந்து ஒரு நாளைக்கு 4 வாட்டி தக்காளி ஜூஸ் குடிச்சாதான் ப்ராப்ளம். ரசத்துல போடுற தக்காளி எல்லாம் நோ ப்ராப்ளம். So you understand. So again, moderation is the key word here, right? So if you've been given calcium for your bone density that's lower and you need it for the well-being of your bones, then I think it's more than acceptable to take it. Combine it with adequate fluid intake. But if you're a recurrent stone former and you've got the calcium stones that are getting formed again and again, then maybe you need to tone things down. So there is something called a metabolic workup that will be done that will tell us how much calcium is coming out in your urine, how much sodium, how much potassium, how much citrate, and based on that we can titrate your medication, right? So we cannot give a straight answer saying that stop pannidunga calcium.
COVID time. Okay. In this COVID time, all my physicians asking to take zinc along with vitamin C and vitamin D. You told that that's not good, taking too much of vitamin C and D.
Too much, that's all right. Too much. One tablet a day is not too much. You're okay. தப்பில்ல. Zinc எல்லாம் தப்பில்ல. Zinco வீட்ல இருக்கிற zinc is acceptable. இதுல வந்து ஸ்பெஷலா விட்டமின் டிக்கு the levels of vitamin D பார்த்துக்கணும். Every time vitamin D முழுங்கிட்டே இருக்க கூடாது. அப்படி முழுங்கிட்டு இருந்தோம்னா then we'll be in trouble. So எவ்வளவு லெவல் இருக்குன்னு பார்த்துட்டு அதுக்கு ஏத்த மாதிரி ட்ரீட் பண்ணி. Vitamin D is good for us, but vitamin D that comes via sunlight is more better than taking via tablets. Goal என்னன்னா go outside, walk, and this days it's a bit difficult, but மொட்டை மாடியில நடக்கலாம்.
Gall bladder stones remove பண்ணா side effects நிறைய இருக்கு. So gall bladder remove பண்ணு.
Gall bladder urinary systemல நான் சொல்லுவேன், gall bladderலயே சொல்றேன், பட் அது பித்தப்பையில வருது gall bladder stoneன்றது. அதுல வந்து யூசுவலா அது நம்மள தொந்தரப்படுத்தல அப்படின்னா பெருசா ஒன்றும் பண்ண வேண்டாம். பட் சுகர் இருக்கவங்களுக்கு, gall bladder stone ரொம்ப பெருசா இருக்கவங்களுக்கு, gall bladder stone நிறைய இருக்கவங்களுக்கு, பிளஸ் சிம்டம்ஸ், நீங்க சாப்பிட்டா ஹெவியா இருக்கிறது, சாப்பிட்டா வலிக்கிறது, ஆயிலியா சாப்பிட்டா டைஜஸ்ட் ஆகாம இருக்கிறது, அந்த மாதிரி சிம்டம்ஸ் இருந்தா அவங்களுக்கு gall bladder எடுக்கிறதுல தப்பே கிடையாது. So gallbladder surgery is probably one of the commonest surgeries, especially for women. அதுக்கு அந்த டேர்மே இருக்கு, ஃபீமேல் 40 fertile அந்த மாதிரி. ஸோ அந்த ஏஜ் குரூப்ல சிம்டம்ஸோட இஃப் யூ தேர் கண்டிப்பா gallbladder சர்ஜரி பண்ணிக்கலாம். பட் ஒண்ணுமே தொந்தரப்படுத்தல, ஒரு சின்ன ஸ்டோன் இருக்கு அப்படின்னா பண்ணணும்னு அவசியம் இல்லை. அது சுகர் இருந்தது பிளஸ் இன்ஃபெக்ஷன் வர மாதிரி இருக்கு அப்படின்னா பண்ணிடுவாங்க. அதெல்லாம் இப்போ மினிமல் இன்வேசிவா பண்ணிக்கலாம், ஒரு நாள் ஹாஸ்பிட்டல் இருந்தா போதும்.
Doctor, there is another question. Like, do you advise usage of diapers for elders to manage incontinence?
So, Vaishnavi madam irukangla?
Yeah, very much here, yes. So in women, the diapers, we are not a big fan of diapers because we think we can treat incontinence. So, hello, can you hear me?
Yes, ma'am.
Yeah. So the bottom line is I'm not a big fan of diapers because we think we can treat urinary incontinence far more effectively than that. So if it is at a stage where we cannot reach the incontinence at all, for whatever reason, if the patient's too old or they have multiple other comorbids, multiple other diseases, so we are just not able to offer treatment to them, then maybe diapers are an option. But diapers should not be used as first line. For instance, you just can't give it out to patients like sweeties and ask them to use it if they have a little bit of urinary incontinence. They need to have an evaluation for urinary incontinence, and if they use diapers, they have to use them as under supervision. Otherwise they end up with a lot of other problems in addition to what they started using it for. So that's my view on people using diapers.
I'll also agree with what Dr. Vaishnavi says. Enga side la kuda even for males, diapers are not a solution. So we need to look at what is the reason for them having incontinence and then start treating that. So in urological practice, we have something called bladder training. So a lot of people have this urge incontinence where they have to go and they have to go and they can't stop and so on. So what we would suggest for them is two things. One is called timed voiding schedule, which means whether you want to go or not, every 2 hours, 6, 8, 10, 12, 2, 4, 6, 8, go and pass urine. So rather than allowing the bladder to tell you, go to urine now, you make that decision every 2 hours and go. So slowly the bladder will align itself to these 2 hours, and slowly you can take these 2 hours to 2 hours, 15 minutes to 3 hours and 3.5 hours. So that's part of bladder training. So that is the way to go ahead and treat incontinence issues rather than get into a simple thing like diaper. That is like a safety zone, Mari, but it's not a long-term solution. So would you agree, Dr. Vaishnavi?
Absolutely, absolutely. Yeah, can't agree more. Thank you.
I have a question.
Yes, please.
The thing is that I've been having urinary problems from 1996, different kinds. The one is, like when you have a urinary problem, there's a lot of mental and emotional stress that goes with it. One is, you find it very difficult to move with others, and you'll have to use the toilet every 5-10 minutes sometimes every half an hour. Well, people are not using the toilet, rest of the people in the room are not using the toilet for 4-5 hours. So it's a very embarrassing kind of a situation which I have faced from 1996. And of course, I've learned to deal with a lot of things, learned to manage a lot of things. But the primary problem is not only you managing, you have an embarrassment factor, but I find, people who are of your age or people who are elder to you also, I don't hold it against the youngsters. They find it very funny that, you have to use the toilet so often. How do you handle that?
Thanks for asking that question, and thanks again for coming out in the open like that. Because, like I always say, our women, especially women from this country, from India, they're very tolerant. Like you say yourself, I've learned to cope with it all, and we can cope with it because they get used to coping with so many things that's thrown at them in life. They cope with urinary incontinence and the embarrassment that comes with it. And I think it takes a little bit of courage to say, I'm not going to put up with this anymore. Yeah. And then kind of moving on to finding treatment. So when you accept it as normal and put up with the embarrassment, that's when it affects your quality of life significantly, not just physically, emotionally, like you say, mentally. It reduces the esteem you have as a person, and that should never be allowed to happen. That should never be able to happen, never be allowed to happen. For instance, what you say, youngsters laugh at you, and normally that would never bother you. Am I right in saying that? No, normally you would be like, you laugh all you want, I do what I want. And it's not just youngsters, ma'am. People across the board are just not sympathetic towards this problem. And that is the fight we have against. I run Urogynae survey clinic where all women over the age of 60, it's like a geriatric master health checkup. We screen them for urinary incontinence. And the amount of resistance there is to accept the fact that, one, they have urinary incontinence as a problem, and two, that there is treatment and they can pursue treatment, and to even talk to family about it, there is just nothing but resistance, ma'am. So for somebody to come out in the open and say, I have a problem and I've been struggling with it, it's quite a feat. So I think it just needs that little bit more for you to get out and get the treatment for it, ma'am.
No, doctor, I have been under treatment. I've always been under treatment. It's my case is a little not so simple as I'm making it. But what happens is, you can't talk about all your problems all the time, or most of the time you don't want to talk about it. It is not the youngsters. At least because the youngsters, I will be more tolerant. I go out, I find it very difficult to go out in a group. Like there's a group excursion, I want to go, I want to be part of it, Like we have a Rotarian who does this heritage walks. I would love to be part of it. But I know I cannot get a toilet there. And I have gone out to different groups, and I find for everybody it's a laughing matter, and I still haven't figured out how to deal with those, that the people laugh at a problem that you have. I'm talking about that. How does one deal with that? I mean, it's not that I've not undergone treatment and things like that. I'm very health conscious. All that is fine. But how do I tackle people who are educated, who may have today they may not have this problem, but tomorrow they may. They don't even think like that.
Yes, yes.
How does one handle people like that?
Yeah. So I think it's looking inside rather than looking around you is what I would tell most patients. Don't let it affect you. Lack of sensitivity is an issue with lots of problems, not just urinary incontinence. So if people want to make a joke out of it, it's their problem, not yours. So if you have, and I'm sorry if I sound a little bit preachy, and I'm sure in your experience you're more than capable of dealing with it like this. But if you have the ability to cope with it and ignore people, that's the way forward. Yeah.
I have a question for Dr. Vaishnavi.
Yes, ma'am.
Yeah, my mother is 77 years old and she's asthmatic like since childhood. And she had a rectocil and cystocil 4 years ago. Mm-hmm. And she was fine until, maybe a couple of months ago. Yeah. And now again, she has started getting those symptoms of, she can't pass the urine completely. Her motion is always eternally having problem passing the motion. Sometimes, it gets very difficult for her day-to-day activities. So yes. I wanted to just ask, should this be repeated quite often, like a couple of years? Again, you have to repeat these surgeries, or how does it, how do we solve the problem?
So prolapse surgeries, especially the ones done vaginally, which is why we're venturing into robotic surgeries, putting meshes in and making surgeries more robust. Unfortunately, some prolapse surgeries aren't very robust, and they can, there is a high risk of recurrence, especially with cystocele repairs. And so there are some risk factors which make some patients more at risk of having a recurrence, as well as the surgical factors as well. So she needs to have an assessment, and because what can happen is if the prolapse recurs, they'll have exactly the same symptoms. So it doesn't matter if they've had surgery, if the bladder has come down to a certain level or the bowel has come down to a certain level, they need it put back. So it might be that you look at other options and you say the patient's your mother, and if she's elderly, there are non-surgical options that we use quite often. So she definitely needs an assessment. And what I do with all my patients who have had prolapse surgeries, I see them on a regular basis. Sometimes it is as simple as to get them to do some pelvic floor exercises, avoid high-risk factors, avoid high-risk behaviors, make sure they don't put on a lot of weight, and make sure we keep an eye on their prolapse status as well.
Okay, yeah. Thank you, Doctor.
Yeah, you're most welcome.
There is another question from Mrs. Parimala. Early diabetic stage, like we urinate every 1 to 2 hours. Will that reduce when sugar is under control? There also...
Yes. Yes, definitely will come down. Yes.
Yeah, I agree too.
Another question, is back pain one of the symptoms of stone formation? From Mrs. Kalarani.
Back pain, back pain is usually on either side when you have a stone. So either left side of, so the spine in the middle, and then you have the left line and the right line. Usually the pain is in the line when you have stones. So it's not exactly in the middle. So it starts out in the back, in the line, not exactly in the back when you mean midline or something. So.
And I have one more question, Doctor. I'm Kalarani here on behalf of Rajina. In this COVID situation, now everyone's advised to drink this Kabasura Kudi Neer. What happens is we drink even quarter tumbler of that every day, most sincerely, religiously. The third day, you land up with some urinary, burning sensation when you pass urine. Then immediately there are people telling you, you're not supposed to drink it every day, drink it once in 3 days. And then when you start drinking once in 3 days, you start coughing, sneezing again. Then people advise, drink, who asked you to stop? So what do we actually do? Is that, I mean, does that have the problem of causing irritation or burning sensation, this Kabasura Kudini?
So I'll be honest with you. I've also taken it for a couple of days. So because my mother wanted me to at that time, some time ago. But I stopped within a day or two because I couldn't stand it. Yeah. But I'm not sure it causes specifically urinary problems. If it does, I would suggest you stop it. So to be honest, I don't know what it contains or anything of that sort. Because it's not part of allopathy. But because the government is saying drink it to everybody, I'm quite certain it's not a harmful entity. So that's my answer. Which is kind of, I'm saying I don't really know the answer to the question that you're asking.
What is the reflex? Reflex. Why does it come for us?
You're talking about urinary reflex?
No, whenever we eat, after that, burning sensation.
Okay. So that's your Ninja Leah. Okay, yes. Right. I understand. So most of the times it's the diet that we take. More spicy food and all that will cause that sort of an issue. The other thing that you need to be careful about is you should not eat too much. Up to the brim is never a good idea. And the other point that is easily digestible stuff is something that you need to take. And people with this burning, heartburn, the best solution would be to take the same amount of diet that you've been taking, but split it into more number of times. For instance, if you're taking breakfast, lunch, and dinner, and I wouldn't want you to reduce the quantity, but increase the frequency. So take something at 8 o'clock, then 11 o'clock, then 2 o'clock, then 4 o'clock, 6 o'clock. So you don't want your tummy to be full at some points in time, but it has to have some amount of food in the tummy, but not too much, right? And another important thing is don't eat just before you sleep, right? If you sleep, as soon as you eat, then there's a lot of food in the tummy that doesn't go out. And that causes some acid reflux getting into your esophagus and causing this sort of an issue. So the points to follow are no spicy food, increase the frequency of meals, but not the quantity of meals, and don't sleep as soon as you finish eating. I would suggest a good walk for about half an hour, or at least 2 hours after you've had dinner, you would go to sleep. Okay? And people with this sort of an issue, I would suggest to raise the head end of the bed by tiny blocks about 1 inch so that you don't have that reflux getting into your esophagus and causing this sort of a trouble.
Thank you so much, doctor. I think we are running short of time. Let's come to the end of the session. Thank you so much for I thank both the doctors for spending their valuable time and educating the people over here. And now I would like to introduce about the another person, Mrs. Roma Bhumik. She is a past president of the Inner Wheel Club, and she is going to deliver the vote of thanks. A short introduction about her. Roma Bhumik has been in Inner Wheel since 1998. She has led the club twice, mainly during its Golden Jubilee, and implemented many worthy projects for the poor and needy. A good singer and a classical dancer, Roma actively involves herself in the grand Navratri festival programs organized by the Bengal Association. Ma'am, over to you.
Thank you, ma'am. I thank Chennai Urology and Robotics Institute Hospital for being part of this webinar. My deepest thanks to Dr. Ananthakrishnan and Dr. Vaishnavi for taking out valuable time from their busy schedule and giving us powerful insights in common urological problems and incontinence in women. I also thank Mrs. Rama Rajesh. She is the coordinator and the key person for arranging this webinar and has dedicated herself to CURI Hospital. I thank PDC Sita and President Kalarani and all our club members and all the other members from different clubs who have attended this seminar, and for all the active participation and very interactive session that we had, and I find it was very easy to talk to the doctors. It was like, it's not that we were talking to a doctor. It was the doctors were very friendly, and I really enjoyed that. Thank you so much. That makes a patient feel very, very comfortable. Then this was indeed a wonderful and interesting session, and I thank one and all for their presence once again for such a wonderful evening. Thank you so much, everybody.
Thank you. Thank you all.